So, thank you so much. It's an honor to be here. I am Philip Dickison. I am the Chief Officer of Operations and Examinations for the National Council of State Boards of Nursing. I want to present to you today what we're working on in terms of what we call the next generation of NCLEX. As most of you in this room probably know, we developed the NCLEX. One of the important things to understand about the NCLEX is it is designed to measure practice. And so it happens after the education program and looks at the first 12 months of independent practice by the entry-level nurse as being the defining element that we would look at in terms of knowledge, skills, abilities, competencies. So the way we get to that and how we got to the next generation NCLEX is really depicted on this chart, which has just been standard operating procedure in our research model for practice over a number of years. And that is, as you can see at the top boxes here, there are two very important studies that occur. They occur every 3 years. One is a practice analysis, and the other one is a knowledge, skill, and ability study. The practice analysis could be thought of as, from an education perspective, and remember, I'm measuring practice, but I'll put it in education perspective mode, something that relates to broader competencies or because I'm old school, when I took my PhD, we called them terminal objectives, right? So I apologize for that, but if you're still there, that's how I got there. And that's how I sort of related back to how does it line up with education in a certain way. The knowledge, skills, and ability then become what you might refer to as enabling competencies or enabling objectives. Those knowledge, skills, what math, what social, what psychology, all of those things do you need in order to meet the practice analysis larger competencies. Why is that important? Because you can see in this squared circle, as it were, that everything leads to the item development. Meaning that if it is important in a practice analysis, then that ends up on the exam. The exam is always tied to activities or competencies from practice analysis. What then defines how items are written and the depth and breadth of those items become the knowledge, skills, and abilities. So that forms the context around the measurement piece. And I wanted to put that out first to show you how we got to, quite frankly, what we believe is the next movement of measuring entry-level nurses. I don't need you to read this. This is a leave behind for you. That's all that was about. But one of the things that comes out of a practice analysis is a belief statement about nursing and the populations they serve. And it forms the foundation by which you build the rest of your test plan. These statements are excerpts from the practice analysis, which you can get up there at the PDF and read the whole thing if you're interested. It is a little long and boring, but it does have good information in it. But ultimately, it defines this nurse as a nurse who is well-rounded in the academics, not just in, let's say, anatomy, physiology, pathophysiology, but also the social determinants, the community, and it also defines the populations they serve as being finite with different relationships, different socials, and that they must work in that environment. So you can understand why building that as the foundation gives us a sort of playing field in which to then develop items. One of the other things that come out of the practice analysis are certain things that we call integrated processes. So you could have all you got an NCLEX, you got a test, it's got test plans. Test plans say we're going to measure you on management of care, we're going to measure you on psychosocial. But across all of the gamuts of nursing, there are certain things that happen regardless of setting, regardless of community, regardless of anything else. They happen as a nurse. We do those things to give the best care to our clients. This is just an example of one, but every one of these in the practice analysis, if you read it, will have some of these things. So I took a look at cultural awareness and cultural influence. That is something that is incorporated, is what we call an integrated process. What does that mean? That means on any item, or when I say item, those are exam questions, all right? Any item that is given to a candidate could be set in the context of cultural health. So for instance, what are some other ones? Nursing process covers the entire gamut of the nursing, of what we do as nurses. So any item can therefore, regardless of the setting, be asked in the context of the nursing process. Communications is one. So you can see that there are about 5 of those. Spirituality is one. Those are items, again, or concepts that can be across all settings. That's important for what we find next. Slide probably doesn't mean much to you, so I'm going to explain it to you, because that's what I do. And I enjoy it. One of the things you do in a practice analysis, remember, is you get tasks and you get skills. And one of the things we started doing was connecting those to find out what task those broad activity statements matched up with skills. And this is an interesting slide because it was a revelation moment for why we needed to move to next generation NCLEX. And that was this. This is just on management of care. There are about 82% of the tasks related to management of care require clinical decision making for the entry-level nurse. Why is that important? Because when we looked at, then we started doing some literature research, if you will, in about 2013. A couple things we found out. 60% of all errors made by entry-level nurses were due to lack or failure to appropriately apply clinical judgment. And of that, 50% of those were related to emergency or critical situations in which client harm could have occurred. So we said, well, if that's true, there was one other thing. Also, 20% of employers, only 20% of employers believed that we were providing them with nurses who were prepared at the appropriate level of clinical judgment. And we said, if that's true, then we've got to look at ensure that the measurement is actually getting to that, so that what we're releasing in terms of scores to say to state boards of nursing, this person is safe and effective to practice in your local area across the United States, that in fact we need to actually measure that. And so we started looking at ways to do this. One of the things we determined, however, was that the current item, the way we write current items, will not do that. And so we needed to look at a different model, and I'm going to show you that model now. I want to talk briefly why this model is important. This is a model that has not been used in measurement. And remember, this is a measurement model. It can be turned into a teaching model, but it's a measurement model at this point. Why this is important? Because most measurement models are linear. They are one line and they go straight across, say, this is how you measure it. And I said, well, that doesn't seem to meet the needs of our nation, because there are different stakeholders in the measurement. There are, in fact, boards of nursing. What do boards of nursing care about? They care about that they are giving a right to work to someone who is safe to provide care to the public. What do educators care about? Well, they care about the same thing, but there's this large thing called clinical judgment. What the educator doesn't have in any measurement up today is the layer 3. Layer 3, no one provides information back at my level where we're providing very rigorous exams on what are the elements of clinical judgment that are not being, that my students aren't getting, that my students aren't performing well on. And so level 3 is where the clinical judgment measurement will occur, and we can collapse that down to a board of nursing and say we know that over the entire clinical judgment model that this person is safe. Or we could say back to the educator, guess what, your programs or your individuals, you can do it program level, state level, individual level, are having some difficulty with hypothesis generation or taking action. Remember the first box that I showed you, the first slide I showed you, that said you have to incorporate those contextual elements. one of the things the literature search actually confirmed for us was that, I'm going to was that context matters. Context matters. You cannot take items. Psychometricians love to take items because we don't like dirt. We absolutely hate dirt. Dirt means there's error in our measurement. So we like to get rid of dirt. So one of the ways to do that is sterilize your items. The problem with sterilizing items, the way we write them today, is they're sterile. And so I tell every nurse, here are the 5 things that's going wrong with it. Why? Because they're all important. But when you and I walk into a room, as nurses, that's not what we see. We see hundreds of cues, of which we have to pare down to those that are relevant and those that are irrelevant. And so what I said to the psychometricians, we got to dirty up the items. They need context. And the context is layer 4. Not measurable, but forms the context in which any item can appear. So you can see there are individual factors, there are environmental factors, cultural considerations, time pressures, consequence. All environmental factors have to be included because that's what our nurses face every day when they walk into a client room or they walk into a client home and have to provide care. And so the idea on our research is that we need to get there. We're looking to do this by 2023. Hope to be able to release the new measurement. A lot of research is available if you want it. I'm going to show you this next slide, your take home, if you would like. These are the 4 newest papers. There are a lot of other information for you that we can provide if it would be helpful. And with that, I bid you thank you.